especially in prostate cancer, and probably in prostate cancer than most of the other tumors, bone plays in the advanced stage a very important role. And the likelihood of advanced, especially castration-resistant prostate cancer, to get bone metastasis is very, very high, as you can see here, compared to other cancers. And if we look at the overall incidence of prostate cancer, then those that are actually get bone metastases is already somewhere in the range of 15–20%. And those of the advanced prostate cancer, then about 90% do get bone metastases. And this is especially those patients that die from prostate cancer are most likely, if detected or undetected, have about 100% incidence of metastasis or tumor cells in the bone system. Now, the extent of bone lesions is associated with an increased mortality, as you can see here, and it's the number of bone lesions that also increases mortality. So that is one of the reasons why we fear bone metastasis in patients with prostate cancer. And the recent advent of better imaging of patients with prostate cancer with the help of PSMA PET CT showed that we do have not only sometimes a downstaging, but especially an upstaging in quite a number of patients, which then influences us in our management of the treatment of advanced and metastatic disease. And that is one of the reasons why we see more bone metastases now and metastasis in general, but that also shows us that what we previously had seen as a high-risk non-metastatic disease now becomes a low-volume metastatic disease, showing us that on the one hand, what we treated initially as a non-metastatic disease is actually a metastatic disease. And if we detect now with the new imaging possibilities a low-stage metastatic disease, low-volume metastatic disease, this may be similar with the high-risk non-metastatic disease. But of course, if a patient develops bone metastasis, depending on the location of the bone metastasis, then almost all patients do experience some form of bone complications, starting from pain, starting from impairment of movement, to fractures. And that is especially when it gets to the spinal cord, compression and fractures of the spinal cord. That is appearing in approximately 8% of all patients with bone metastasis due to prostate cancer. And that is a terrible situation for the patient, being bedridden or cannot move apart from enormous pain. Sometimes that leads to an enormous problem, not only for the patients, but for the health care system, because these patients need a lot of resources for their treatment and especially for their symptomatic treatment. And of course, as already previously said, any bone metastasis, especially then in a severe location like the spinal cord, will then decrease life expectancy. And it is also clear that what we could do is we could treat the bone metastasis, but Of course, there is an improvement sometimes, in some cases, especially in the oligometastatic disease, if you do a metastasis-directed therapy. But the actual advantage of treating the bone metastasis is quite low. Higher is the effect of the treatment of low volume, again, low volume oligometastatic disease when you treat the primary treatment, and the HORAD and trial have shown that this treatment of the primary in the oligometastatic disease is beneficial with regards to overall survival. And the earliest treatment of bone metastasis in an isolated form was the Alsimca trial, looking at radium-223 as a possibility of treating bone metastasis. And at that time, it was the only or the best way of treating the bone metastasis by nuclear medical form of treatment. And you can see here there was a survival benefit simply in by treating bone metastasis. And even more so, it was possible to show that the first symptomatic skeletal event, any of those from pain to fracture as a worst form, it did show that it could delay that, and it could improve, of course, then not only the patient's symptoms and the patient's problems, but also the resources of the healthcare system, again, if patients did not develop fractures. And how do we know that that we do any benefit to the treatment of bone metastasis, not only by imaging but also by bone markers such as alkaline phosphatase? And the bone-specific alkaline phosphatase did show in the Alsimca trial, in the comparison group, control group, that the alkaline phosphatase, even in the untreated, did show a correlation with the overall survival. So in other words, alkaline phosphatase, especially the bone-specific alkaline phosphatase, is a valuable bone marker or biomarker for the fate and the activity of bone metastasis. Now, bone-targeted therapy overall does show a survival benefit. Saad has shown that several years ago, that if you look at the bone targeted therapy versus no bone targeted therapy, there was a difference between the two. So the survival overall does show a benefit, and that may be with systemic therapy as well as regarding to the bone-specific radium-223 treatment. And if you look at the type of metastasis, or the type of bone metastasis, being either osteoplastic or osteolytic or mixed, then especially in the prostate, probably more than in the breast cancer, as you've just been shown, that it is mainly osteoplastic, and the prevalence being very high, as already mentioned before.